Right, welcome everyone. We're going to start the next session, which is going to be very interesting and exciting, and so we don't want to delay starting. So this session is going to be reading with the experts on aortic stenosis. We've got 4 fantastic speakers lined up, and please do not forget to put in any questions you may have on the Slido for both people who are attending in person as well as online. And then we will have, after the 4 speakers, have a Q&A session when that would be a great opportunity to sort of ask all the questions you've been, you want to get answered. So without further ado, we will get started. First speaker is going to be Shaun Robinson, consultant clinical scientist, the co-chair for the Education Committee for BSc. He needs no further introduction. I've worked with Shaun before, and Shaun, over to you.
Thank you very much. So I've changed the title of my talk slightly from advanced parameters to non-routine measures, because that's exactly what they are. They're measures that we don't apply routinely. We shouldn't consider them as a next level up from our standard method of assessment. They've got very specific application for consideration, but they are non-routine measures. So I've got just 2 cases, one case of low flow aortic stenosis and another case of high flow post-aortic valve replacement. The first patient is an 83-year-old male. He's 1.66 meters tall, 84 kilos, with a body surface area of 1.9 meters squared. His background history is relevant for a bypass grafting in 2005. He's hypertensive, peripheral vascular disease, ex-smoker, and the echo in 2019 suggests that he had low normal LV systolic function, which in the context of ischemic heart disease probably suggests he had some mild impairment and mild aortic stenosis. His presentation this time round, he's got a 6 to 8 week history of increasing dyspnea, orthopnea and PND. He's now breathless after walking just 30 to 40 meters, and he can't walk and talk at the same time. However, he's not experiencing chest pain, palpitations or presyncope. On examination, he was in sinus rhythm at 80 beats per minute with atrial ectopics and T-wave inversion laterally, bibasal crepitations but with otherwise good air entry, mild pitting edema to both knees, and his NT-proBNP was above 2,000, so he was referred to our rapid access heart failure clinic where he underwent echo and clinical review. And at this point, the suspicion was of systolic heart failure secondary to ischemic heart disease. So he had an echo, and this is a parasternal long axis view. You can see he's got, it's not projecting very well, but he has infralateral akinesis. His septum is markedly hypokinetic. In the parasternal long axis view, LV systolic function looks pretty poor. He's got a dilated left atrium, so in the context of sinus rhythm, this probably suggests raised left ventricular filling pressure when we have a ventricle that looks like this. The aortic valve appears thickened and calcified with reduced excursion, and RVOT function looks normal. Apical 4-chamber view confirmed extensive regional wall motion abnormalities. The ventricle looks a bit dilated. You can see the apex is looking a bit rounded. Overall systolic function looks quite severely impaired. And again, in that 3-chamber view, you can see the valve looks heavily calcified and excursion looks reduced visually. So assessing his aortic valve, the peak velocity and mean pressure gradient were low, as we'd expect with a poor LV function. The valve area was calculated at just above 1 centimeter squared, and the index was around 0.5 centimeter squared per meter squared, with a dimensionless index of 0.26. So pointing towards moderate to severe AS. The stroke volume by continuity was calculated at 59 mils with an index of 31. So the echo report described sinus rhythm at 90 beats per minute, a blood pressure of 158/77, LV systolic function severely impaired with an EF of 26%. GLS was markedly reduced at -7%, and again those transvalvular velocities and mean gradient were low because of the low flow state. But we thought that the continuity estimate of stroke volume was probably a little high. We thought it might be overestimated. Stroke volume of 59 with an index of 31 in the setting of severe aortic stenosis we thought was probably overestimated. And at that stroke volume, we calculated the flow rate to be 208 mils per second, which is important. So this suggests that being above 200, the valve is probably opening as much as it possibly could do. And with this stroke volume, we calculated the valve area to be 1 centimetre squared. However, because we thought this was inaccurate, we calculated the stroke volume by Simpson's biplane method. And this we calculated at 47 mils with an index of about 25, which we thought was probably more consistent with severely impaired LV. And importantly now, the flow rate has gone from 208 mils per second to 166 according to this stroke volume, which may suggest that the valve might not be opening as well as it possibly could do because it's such a low flow state. And at that stroke volume, the valve area is calculated at 0.8. So overall, the conclusion was that this is probably moderate to severe aortic stenosis. So my colleague came and asked what we should do with this chap next, and all of the answers to your AS questions are in the AS guideline that Liam wrote. It's a brilliantly comprehensive guideline that gives you tips and guidance on every scenario for aortic stenosis. And in those with low gradient impaired LV, so low ejection fraction, once we've excluded technical error as the cause of our discordance, then we should consider a debutamine stress echo to see whether we can increase the flow rate and see whether the valve opens more if it's pseudo-stenotic, or increasing flow, the valve is rigid and truly stenotic and gradients increase. As part of that, we can consider calculating the predicted orifice area at higher flow rates. And if they're inconclusive, we can then consider CT calcium scoring or an MDT approach to answer the challenging question. But let's have a look back at the chap's echo summary. So he's a guy who's got severely impaired LV systolic function. His EF's 26%, his strain is -7%. So that's a ventricle that's not contracting normally. It's poor function. And he's got severe aortic stenosis. But his systolic blood pressure is 158 millimeters of mercury, and removing the severe AS in people who've got poor left ventricular function, we usually see that the blood pressure is a lot lower. And so then you add aortic stenosis to that, it doesn't seem to make sense that we're seeing high systolic blood pressure. So it seemed that the high blood pressure was inconsistent with truly severe LV systolic function and moderate to severe aortic stenosis. And in fact, the combined afterload of high blood pressure, high vascular resistance with the degree of aortic stenosis could be equivalent to severe AS and therefore contributing to the low ejection fraction and the chap's symptoms. So the recommendation was optimize the blood pressure control, and then we'll re-echo in a couple of months before we go down the route of a DSC or a CT, which is what we did. And he came back a couple of months later. I'm not sure if that's projecting well, but you can see the LV has decreased in size. It's no longer looking pressure loaded or volume loaded. The apex is not looking rounded, so it doesn't have an appearance of sphericity. And the ejection fraction has increased quite significantly. Looking at the aortic valve, the parasternal long axis and short axis, this wasn't a picture of severe aortic stenosis. So there is a degree of AS, but the valve visually appears to be opening to an extent. Echo report, so his blood pressure was calculated at 117, his systolic, or was measured at 117 systolic. AF had increased to around 50%, strain had also increased to -11%. Again, the stroke volume by continuity we thought was a bit overestimated at 76, I think it was. So by Simpsons, we got it at 68, which gave us a low normal stroke volume index of 36. And importantly, at this stroke volume, the flow rate is above 200 mils, which now suggests that the valve is probably opening as much as it possibly could do. Peak transvalvular velocity and the mean pressure gradient didn't remain the same despite the increase in flow, because the valve area had now increased to 1.3 centimeters squared. So this clearly was moderate aortic stenosis that had been exacerbated by high blood pressure. And with his blood pressure control, his symptoms improved significantly. And previously, we've calculated ZVA in this scenario, and ZVA is a really simple calculation. It's the mean gradient plus the systolic blood pressure divided by the stroke volume index. And this is a reflection of the total load faced by the left ventricle. But we don't recommend the measure of ZVA anymore. There are lots of reasons why the stroke volume index might be reduced, so poor LV systolic function, LV diastolic dysfunction, other valve diseases. And if the stroke volume reduces for any other reason, then the ZVA will increase irrespective of the afterload faced by the left ventricle. But assessing blood pressure and reporting blood pressure is crucial in our patients with aortic stenosis, because as blood pressure increases alongside that aortic stenosis, that increases left ventricular afterload and LV wall stress. And the wall stress is the resistance against which the left ventricle is contracting. And we certainly don't recommend calculating wall stress by echo, but it's a fairly straightforward calculation of multiplying LV pressure by LV radius and dividing that by 2 times our wall thickness. So you can see that as if LV pressure and radius remain the same, as LV wall thickness increases, then your wall stress decreases. And so hypertrophy secondary to aortic stenosis is that compensatory mechanism that overcomes that wall stress and allows the ventricle to continue to contract normally with a normal ejection fraction. However, when that wall stress exceeds the compensatory mechanism of hypertrophy, then the ventricle can't overcome that, and that's when we see the ejection fraction starts to deteriorate, which is what happened in this patient. And so our echo guidance recommends that we perform our echoes when the systolic blood pressure is less than 140 millimeters of mercury. So moving now to the second patient. This is a complex patient, and I don't think it's a clear-cut answer at the end. The patient's a 74-year-old female. She's short in stature, so 1.4 meters tall, 46 kilos with a body surface area of 1.3 meters squared. She lives alone, she's independent, so she lives in a house, so she can climb stairs. Had a tissue AVR in 2018. This was a 19 millimeter Carpentier-Edwards perimount, so quite a small valve. The surgeon attempted to implant a 21 millimeter, but that wouldn't fit within the annulus. She has rheumatic arthritis with significant hand and feet deformities. She's previously been anemic, hiatus hernia, kyphoscoliosis. She can't lie flat. The echo was performed in a semi-upright position. And unfortunately, she has pelvic floor failure with vaginal and significant rectal prolapse, which is severely impacting on her quality of life. The echo performed post-operatively at her local hospital couldn't visualize the aortic valve leaflets, but the peak velocity was measured at 4 meters per second, the mean gradient at 38, with a valve area of 0.7 centimeters squared. LV systolic function appeared normal, with normal EF and strain, and the echo report queried whether this could be a degree of patient-prosthesis mismatch. However, the plan was, at this point, despite the recommendation of possible mismatch, was to optimize her anemia and see whether that explained why she had high gradients, but it wouldn't explain the lower calculated aortic valve area. So before we continue with this patient, let's consider what that suggestion of patient-prosthesis mismatch means. And we heard from Sandeep yesterday that we get prosthesis mismatch when the valve that's been implanted is too small for that patient's stature. And that larger stroke volume through the small valve just results in high transvalvular velocity and therefore mean gradient. The valve's working entirely normally, it's just too small for that setting. And we can calculate whether we think they have a degree of patient prosthesis mismatch by dividing either the measured effective orifice area on the echo or the manufacturer's recommended effective orifice area by the patient's body surface area. And if that's between 0.85 and 0.65, this suggests there's a moderate degree of mismatch. If it's less than 0.65, this suggests that there's severe prosthesis mismatch. Gradients we know are flow dependent, but it's typified by high mean gradients postoperatively. And it's common, according to which report you read, between 20 and 70% of patients who have AVR have a moderate degree of mismatch, whereas nearly 10% will have a severe degree of prosthesis mismatch. But how do we differentiate it from true valve dysfunction, especially when we can't see the leaflets? But how do we differentiate from true, because it's an important thing to consider because they're completely different management options. And so we suspect it's mismatch if the measured effective orifice area is within one standard deviation of what our manufacturer's recommendations are. So in our patient with the 19 millimeter Carpentier-Edwards, the effective orifice area was suggested at 1.1 centimeters squared with a standard deviation of 0.3. So anything down to 0.8 and high velocities, we would consider this to be consistent with a mismatch. Because the valve works normally, leaflet morphology and mobility are normal. And unlike valve dysfunction, which is degenerative and therefore progressive, prosthesis mismatch is evident immediately after the surgery and then on all subsequent echoes. So it's not something that will develop over time. So going back to our patient, she's anesthetic assessment prior to her surgery. And that's why she's having the echo because of her previously high gradients. She's still managing her daily activities without breathlessness. So she's cleaning, cooking, manages the stairs, and her pelvic floor failure is her main limitation, is keeping her nearly housebound. So let's have a look at her echo. We were hampered by acoustic shadow of the leaflet, so we really couldn't see the leaflets to comment on valve function. But we got the impression that there's probably a bit of cusp thickening, a bit of leaflet thickening, but that excursion doesn't look to be severely restricted. Again, we certainly don't routinely assess the aortic cusp excursion in the 5-chamber view, but in this view, we got the impression of this being thickened, a slight calcific appearance, but with some degree of excursion again. The Doppler assessment, we got a peak velocity of 3.7 meters per second with a mean gradient of 31 and a valve area calculated at 0.6 centimeters squared. We noted that her aorta was a bit small with a sinotubular junction of just 20 millimeters in diameter. LV function appears normal. And we thought that at this point, given that the valve area is estimated at 0.6 centimeters squared and therefore is beyond one standard deviation from the manufacturer's recommendations, that the mismatch was unlikely and that we had to exclude valve dysfunction. And because of her kyphoscoliosis, she couldn't lie flat, so she couldn't tolerate a CT. So my colleague performed a TOE to visualize the AVR to assess cusp excursion. And again, this was tricky. So there was, again, acoustic shadow of the leaflets, but we saw that the leaflet in the right coronary cusp position was thickened with some reduced excursion. But the valve didn't look severely stenotic and not consistent with a valve area of 0.6 centimeters squared. So now we initially thought it was this mismatch. We kind of said this is not severe valvular dysfunction. There's an element, but it's not severe. So then we considered her small aorta. And small aortas are conducive with pressure recovery. And the reason we see pressure recovery is that the pressure within static or slow-moving blood is high, whereas the pressure within blood that's moving very, very quickly is low. And so when blood moves through a valve into a normal-sized or large aorta, where the static pressure is higher, that blood velocity decelerates very, very quickly. And what we measure on continuous wave is a true reflection of the pressure difference between the LV and the aorta. But when the aorta is small, then the high velocity is maintained further from the valve. And because it's high velocity, the pressure within the aorta remains lower, and that pressure only increases as the blood velocity decreases further away from the valve. But on echo, we measure that maximum pressure difference. And what's hemodynamically important is the recovered pressure difference, not the maximum that we measure on echo, which is why catheter is better for assessing transaortic pressure gradients when we have an element of recovery, because they can position the catheter further from the valve and measure the pressure in the aorta there. There are calculations that we can consider and take into account when we think pressure recovery is a factor in causing our high gradients, our low aortic valve area. And in this scenario, we recalculated the valve area to 0.75 centimeters squared from 0.6. We were reassured by the TOE that this is not severe valve disease, but by performing this calculation, it increased the valve area to 0.75 centimeters squared, which is now approaching that lower limit of what we'd expect in a valve that's working normally, but with an element of patient prosthesis mismatch. So this was our conclusion, and I think it was one I don't think I don't think it's very clear cut. We could have known from before the patient had the valve implanted that it's a 19 millimeter valve. We know what we expect the effective orifice area to be, so dividing that by her body surface area even before the operation, we know that there's likely going to be a mild to moderate degree of patient prosthesis mismatch. And then when we corrected her valve area for pressure recovery, this brought this up closer to supporting that there might be an element of patient prosthesis mismatch with some degree of valvular dysfunction, albeit not severe, but that in fact the pressure recovery, where the high velocity flow through the aorta, was contributing to the high pressure gradients in our low aortic valve area. So in conclusion, always consider systolic blood pressure when investigating aortic stenosis, and really don't be afraid to recommend a repeat echo if you think high blood pressure is affecting your parameters of AS and certainly your LV function. Remember that patient prosthesis mismatch is not valve dysfunction. That valve is working as well as it possibly can, but it's just too small for the size of the heart. And if you're finding you have high gradients, the aortic valve area is low, and your aorta is small, always consider pressure recovery, but you don't always have to consider correcting the valve area. Thank you.
Thank you very much, Shaun, for that excellent talk. Our next speaker is Stephanie Curtis, who is a cardiologist from Bristol, who's going to be talking about bicuspid aortic valve assessment. If you have any questions, please put them through on the Slido. Thank you.
Thank you. Thank you for that introduction. Thank you, BSc, for asking me to talk. So this is a bit more straightforward than that, because that was so difficult. I'm not very good at all the maths and physics, although I used to think I was. So I was asked to talk about bicuspid aortic valve, aortic stenosis. It's kind of hard to talk about that in isolation without talking about the bicuspid aortic valve in general, but I will try to stick to my remit. The first thing to say is that bicuspid aortic valve disease, and you note that I will always say bicuspid aortic valve disease, because it's actually not a disease of the aortic valve. This is, of course, a very facetious thing to say, but the point I'm getting at, it is not solely a disease of the aortic valve. So the bicuspid aortic valve is a phenotypic expression of some genotype we don't fully understand. We do in some people. In Louis-Dietz, for example, it's more common to have a bicuspid aortic valve, but in many patients, they have a lot of other things going on, and a bicuspid aortic valve is only one of those things. So if you see a bicuspid aortic valve on an echo, the first thing that you need to think of is, I need to look at the rest of the heart really thoroughly. So what I'm going to go through is what is a bicuspid aortic valve. We'll talk a little bit about the aorta. I've only got 20 minutes, which is long enough for us probably to get a new Prime Minister, but maybe not long enough for me to finish this talk. Associated lesions, assessment of the stenosis in a bicuspid aortic valve, and then the surgical questions that we ask ourselves when we're going to be sending the patients to surgery, the kind of questions the surgeons are going to want to know. So what is a bicuspid aortic valve? Well, these are the guidelines telling us what it looks like. Thankfully, there's a new classification. There have been lots of previous classifications. I think you probably maybe heard of the Sievers classification, which is very surgical. A lot of them weren't really all-encompassing. And so it was felt that there was a new classification required. And last year, this was published in a number of different journals. And I just wanted to tell you a bit about it because it is very important. And the group of people that did it were world experts on cardiology, echocardiography, surgery, genetics, embryology, everybody. And so there was input from everyone, really, and so we need to do what they say, effectively. The reason it's quite useful is that the way they describe it takes into account the broad nosology of the condition. So with bicuspid aortic valve disease, you get everything from this sort of very mild disease that you can see here on this side, where you might pick it up incidentally and there isn't really anything else going on, right through to the babies that are born with very complex disease that might lead to other problems with development of their heart, such as hypoplastic left heart and so on. But most of the patients we probably see are these typical sort of bicuspid aortic valve disease with a bit of aortopathy in the middle. But the new classification helps with that sort of nosology, if you like. So this is what it is. You have three types. There's the fused bicuspid aortic valve, so 2 of your leaflets will be fused. I'll talk about that in a second. I used to like non-separation. I still like non-separation because technically that's right, but they did have embryologists on the board or the committee of this writing group, and they call it fused, so I can live with that, and it's much quicker to say. Then there's the 2 sinus bicuspid aortic valve, speaks for itself, and then there's the partial fusion or form first. Okay, so this is what people call a functionally bicuspid aortic valve, I think. I'm very happy that term has gone in the bin because it's one that I really particularly hate. Mainly because if you say something is a functionally bicuspid aortic valve, that means it's a bicuspid aortic valve, which means it is bicuspid aortic valve disease and all the other things that go along with it. So this is all the same thing, just different degrees of it. So the fused one is the one that we see all the time. Right and left is the most common, so that is what we see most of the time. There are 3 sinuses, 2 cusps. Again, they call them cusps. And Bob Anderson, who's a very famous morphologist, said, they are not cusps, they are leaflets. Cusps are things that you have in your teeth, which are elevations, which again is technically correct. So I prefer to call them leaflets, but I will call them cusps. 2 commissures, they're a raphe, and it's an asymmetric valve typically. Then you have the 2 sinuses, which is nice and symmetric, 2 sinuses, 2 cusps, 2 commissures. It's rare, more rare. And then we don't really know how common this other one is, mainly because people haven't really been calling it a bicuspid aortic valve. But it's very symmetric, 3 cusps, 3 sinuses, 3 commissures, and a little raphe. So this is it in a little bit more detail. This is the fused type, and you can see at the bottom there's right and left fusion, which is by far the most common type, right and non, and then left and non, which is vanishingly rare. And then the two sinus type, you can have lateral-lateral, which is more common, or the anterior-posterior, which is less common. Usually have a coronary sinus coming off each, sometimes two coronaries coming off the anterior in the anterior-posterior type, and then the form first at the bottom. So this is the sort of from normal to abnormal. So the most normal type is our old functional, our form first, the partial fusion, and this goes right through to the lateral-lateral two sinus. And the most common type in the middle, the fused type, it can go from very asymmetric to very symmetric. And the reason this is important is this is not stenosis, but when it comes to regurgitation, you'll quite often get prolapse of one of the large leaflets, and it's easier for the surgeon to repair it if it's quite symmetric, because they make it a bicuspid valve, like one on the right-hand side here. They do what's called bicuspidization of the valve, and that's easier to do than trying to make it look like that. So these are the types that we see. They're all moving, which is great. For some reason, the left non hasn't moved for years and moved this morning, which is rather fortuitous. So there's the right-left. You can see there's a non-coronary leaflet, cusp. Right and left are fused. Right and non more rare. So there's the non and the right fused together. You usually get more thickening here and more stenosis, and I'll talk about that. And then that's the left on this side. And then this is actually a child. This is vanishingly rare. I've only ever seen a couple of adults with this, and I can't remember their names, so I couldn't get their pictures for this meeting, but that's one that I stole from someone else. So these are the other types. So this is the form first, the partial fusion. So it looks like a normal valve, but you have to look at it when it's open. Sometimes this is really hard to pick up, and I've not picked it up on some people where I've really suspected a BAV, family history or whatever, and I've seen it on CT or MRI or something like that. This is the two sinus lateral one, which is really the most common two sinus type. Remember, that's pretty rare. This one I'm pretty sure doesn't exist. I don't remember seeing one. Certainly couldn't find one for this talk. They'll be out there somewhere, just like unicorns. But that's what it looks like on MRI. So the anterior leaflet at the front of the heart, and then the posterior one like that. What is this, you may ask? So this is a patient that came along pregnant. This is a classic interventional cardiology story, because she came along with a bit of chest pain, had an angiogram, and then had an MRI. And then the MRI said, there's a bit of AR. And then she had an echo. Lovely tertiary care there. But she has a quadricuspid aortic valve. These are not in the classification, nor are unicuspid, which again are a bit like unicorns. There's always a RAFI there somewhere. But these are on the spectrum, but they're so rare that they're not really included in the classification. And quadricuspids don't tend to cause so much of a problem. They get a bit of aortopathy, but not so much. But they're still in the same umbrella of disease. Unicuspids tend to be in the more severe end of that spectrum that I showed you. So if we talk about the aorta, you all know probably a lot of this. This affects sort of 40 to 70% sort of point prevalence of patients that you see with a bicuspid aortic valve, but not all of them will end up with a problem. But actually about a fifth of them will need surgery in their lifetime, which is a reasonable amount when you think about it overall. And the type that people always think about really is the ascending aorta type, and that is the most common. And it used to be that people would say that if you had the root phenotype, which is 20%, that meant that you probably had some other thing like Marfan's and so on. I've seen that so many times, and that's not the case at all. You get this with bicuspid aortic valves, more common with AR, and more common with right-left fusion, and more common in men, which I'll show you. And then there's the extended phenotype. So we used to talk really about the arch, but actually it's really an extended phenotype, which is either the root and the ascending, or the ascending and the arch. And it's really, really important to look at the arch, because there's no use going and having your aortic surgery and then coming back and saying, well, there was a 50mm arch, and we kind of didn't look at that. That doesn't happen, of course, but you know what I mean. So the root and the ascending is a more common phenotype than the ascending and the arch. So I'll just show you what these ones look like. There's a typical root phenotype. Often you'll get asymmetric leaflets, and I would say that echo can often underestimate aortic size, and that's because often you get a bit of asymmetry. So we measure it in one plane. Normally in MRI, they can measure it in all planes, obviously in CT. But it's worth looking at it on the 5-chamber view, and also in the short axis, so particularly in patients with asymmetric valves. It looks a little bit almost like a sinus of valsalva aneurysm, so it's important to try and measure it wherever you can. This is absolutely typical of ascending aorta phenotype, so the sinuses are preserved. This is really important because it means the surgeon doesn't have to replace this bit. So really important to measure in all your places as you would normally. And this is an arch phenotype. And as I said before, the extended type is either the first two or the second two. I could talk about this for a long time. It could be very controversial. let's not go there. Measuring the aorta. Personally, I do leading edge, sorry, BSE. It correlates more with the internal diameter and diastole on CT, and all the Marfan's data is based on that. But you can do it whatever way you want, as long as you do it the same way and you say what you're doing and you use the right reference data. Avoid the terms mild, moderate and severe because it totally depends on the individual scenario. If the patient has a family history of dissection of everybody in their family age 20 and they have an aorta of 42, you might think that is mildly dilated, but I'll be sending them to the nearest surgeon that will take them. The other thing that's really important is indexing. So we used to index quite a lot by body surface area, but as everyone gets more fat over COVID, including myself, broken leg, etc., we really can't use that anymore. We need to do it by height, and most of the guidelines now suggest that you index by height. This is a patient I saw with a 50mm aorta. She was pregnant at the time, actually, 4'11" though, so that was her indexed height. And that was it for per body surface area. The time we use body surface areas in Turner's because the data suggests that we should be referring patients at 27mm per metre squared for surgery in their aorta, 25 if they have a cohort or a BAV. But it's really important to take into account body size, and it works conversely the other way if you have a very tall person. It doesn't work so much really when it comes to referring for surgery because we refer for surgery at certain sizes, not index sizes, but it's very, very useful in terms of determining what's normal. And actually what matters is really, is it normal or not? Do they need surgery or not? And everything in between doesn't really matter so much. It really just matters how it was compared to the last scan. So why do we get the aortopathy? Well, people used to think it was some sort of strange gene thing, or we didn't really know, but we're pretty sure now that it's due to the flow patterns, and there are lots of MRI studies showing this. So this is normal laminar flow in a tricuspid aortic valve, and you can see in the right-left fusion, which the commonest type, you get dilatation of the root and the ascending aorta most commonly, and in the right non-cusp fusion, because of the way that the flow is directed, it comes across here and then it tends to go to the ascending aorta, and you get more dilatation in the ascending aorta. This is not absolute, of course, but this is what people think. There are different embryological, different stem cells, if you like, end up in different parts of the aorta. And so there is some stuff about that in the kind of Marfan's, Louis Dietz world, but for bicuspid aortic valves, there's a lot of stuff on this now. There is some genetic influence, and I'll come to that in a second. This is a really nice study, and there's some just fantastic papers out there with tons and tons of patients with BAVs. It sounds like heaven. You know, they all come in and you look and see what they're like. This is a machine learning one, 656 patients, and they're trying to work out what kind of phenotypes they had. They were undergoing surgery, so they all had big aortas. And you can see here that the arch phenotype is really favoured by the right non, and that's what I said, I think, before. So it's more ascending and arch. Men, it's the root. Aortic regurgitation, it's most commonly the root, and right and left, I think I said. And aortic stenosis, often it's the arch as well. So right and non and arch are the aortic stenotic type phenotypes that you see. And the aortic stenotics are more likely to have an extended phenotype. You're more likely to get an event if you have coarctation, so that's very well evidenced. And also if you've got an underlying aortopathy. So Marfan's, BAVs are not more common in Marfan's than normal. And if they have a BAV, they're no more likely to dissect than if they don't have a BAV. But in Louis Dietz, it's about 6% patients have BAVs instead of like 1 or 2%. If you have an ACTA2 or MYH11 mutation, so hereditary thoracic aortopathy where you're not dysmorphic, you have an increased risk, obviously, of an aortic event. Just a little note there, the right and left tend to dilate more rapidly, but we're still talking 0.3 to 0.5 millimetre per year compared to Marfan's, which is about 1 millimetre a year once they start to get on the move. So associated lesions, there are loads of them, and there was a talk on this yesterday by Dr. Massani, which covered a lot of this. This is a bit of a word cloud, so the big ones are the ones that are more common. But anything on the left side you can get. And I'm going to show you just a few examples. This patient has bicuspid aortic valve aortic stenosis, but he also has subaortic stenosis and a very small root and annulus. And actually, he's had a number of valvuloplasties throughout his life because there's simply not enough space to get a decent-sized valve in, and you would end up with what Shaun was saying, the type of patient prosthesis mismatch. And you'd have to enlarge the annulus, do a cono, enlarge the LVOT, which is major surgery, and there may not even be enough space to get a good result there. This is a patient that came along to us from Cardiff the other day. He was a bit breathless. It's a patient that kept on giving, really, because we found a coarct. And then when he was in theatre, it turned out that he had this beautiful double orifice mitral valve as well. And you can see how thickened this valve is in keeping with the aortic stenosis. And you can't really see the original phenotype, but this was actually seen on the transthoracic as well. Check the left ventricle. So they all have hypertrabeculation to a degree, and again, it is completely on a spectrum. So you'll get everything right through to a little bit of, maybe it is a bit, right through to what this patient has on the right-hand side. And again, this was a lady who came to me, lost to follow-up post-coarctation repair as a child, and she had the whole works of left-sided lesions. This is a patient who has Shaun complex, which is what you call that when you have all these left-sided obstructive lesions. She sadly died last year of heart failure in the end, and that's what her ventricle looked like. She had subaortic stenosis, a bicuspid aortic valve. This isn't her, but she had a parachute mitral valve. You can see here only one papillary muscle, which is very common. Often they don't really cause issues in terms of functionally, and we quite often pick them up as adults because they're quite difficult to diagnose. And this is the patient I was talking about a second ago. He came along with a coarctation with that very trabeculated ventricle. She actually had a really small mitral annulus, so like functional mitral stenosis, but there's nothing you can do about that because you can't put a big valve into a small annulus. So always check the descending aorta. I know you would all obviously do that, but you're looking at the arch, check the descending, and this is the classic pattern of coarctation of the aorta I'm sure you'll recognise. This is an MRI picture just showing a small aorta, and sometimes these people with small outflows will often have slightly hypoplastic aorta and have high blood pressure, and there isn't really anything you can do about that. VSDs go along with it as well, so if you don't look, you don't find. I mean, you can hear these clinically, but quite a lot of these patients will have VSDs as well. So assessing the stenosis is the same that you would normally, but I just wanted to show, again, this is from Arturo Evangelista in Barcelona's group, who's a massive bicuspid aortic valve expert, a bit like Dr. Rana is in mitral valves. And this showed, I'll just go back a second, looked at 852 patients in all these different centres. Half of the patients actually had normally, functionally normal valve. Half of them had regurgitation, half had stenosis. But the interesting thing is the stenotic patients often had traditional risk factors. And again, from the same group, there is evidence now that if you actually relate those to the progression of disease, the stenosis and the aortic dilatation, it is related to the hypertension and dyslipidemia and smoking. So if you can control the risk factors in those patients, you're doing them a favour. When you're assessing the stenosis, remember the flow is variable, and so the Dopplers can be very variable. And there are numerous examples of this. This is another pregnant woman, so 4.75 metres per second on the right parasternal window in Truro. I did it on a scanner without a pencil probe in our cardiac antenatal clinic. Couldn't get more than 3.8, so I knew it was there, but I just couldn't get it. So try lots of different windows. And what often happens also is, this is a patient I saw in clinic, and they said, okay, my peak velocity that I could get was 2.1 metres per second, and I went, that can't be right because last year it was 3.2. And so back he went for another echo, and then it was 3.55 on the right parasternal window. So look at the last scan, look at the last numbers and make sure you're getting it right. Shaun has covered this, thankfully, so I don't have to explain the physics of this. But quite often bicuspid valves will tunnel when they open, and so you get this flow acceleration through them. So we often talk about velocities, not gradients, because you're using the modified Bernoulli equation isn't really right because you're getting acceleration of the flow throughout, which is the same as subaortic stenosis. This is another pregnant patient. Many echoes she had a peak velocity across her valve of 4.2, 4.3 metres per second. This particular scan, 3.8. And the crucial thing that we look at often is the strain. So strain is really important in aortic stenosis, and there is evidence now, yes, of course, if your ejection fraction is reduced, there's an increased risk, but strain is actually more sensitive than EF when it comes to predicting risk. So we do strain and BNP in everyone, and I really am not massively interested in ejection fraction in these people. TOE don't really do for this, but TOE is the test of choice for the LVOT. So measuring the annulus and looking at subaortic stenosis. This patient in the middle has quite exuberant accessory mitral valve tissue, again, something that you see. The annulus in the bicuspid aortic valve is often oval, so on 3D you can quite often get some nice orthogonal measurements of that. And then just the last slide is just for the surgeons. I know there are no surgeons in the room, but the things we need to tell the surgeons. A lot of these young people get the Ross operation because it means, well, for the children, it means their aortic valve can grow. But for the adults, you do replace one valve problem with two. You take your pulmonary valve and put it in the aortic position, for those of you who don't know, and then you replace the pulmonary, which usually does really, really well and is a less important valve that you can replace by keyhole later on. So it's really important you get very nice views of the pulmonary. Of course, you'll always put that in your report, but we're always going back and looking at it, and sometimes the day before the surgery, we'll have to bring them in again just to look at the pulmonary valve. And we had one patient go to theatre for a Ross operation, couldn't have it because she had a bicuspid pulmonary valve, which you're not going to pick up an echo, the leaflets are so thin, but just important to get really nice views and get a really nice measurement of the annulus in end systole. And of course, the arch is really important. So they want to know how much of the aorta they need to replace. Of course, we do CTs and MRIs and so on top. And the number of sinuses is also important. I mentioned the bicuspidization type repair, but we often do an operation called the Ozaki operation, where they make an aortic valve out of autologous pericardium. And you need 3 sinuses to do that. So you need a nice symmetric valve with 3 sinuses. That's all I want to say. Just want to thank my echo team, who are amazing and took most of these lovely pictures. The rubbish ones were mine. And our cardiac anaesthetists who have done the TOEs. Thank you.
Great, thank you, Stephanie, for a fantastic talk. We'll move on to the next speaker. So it's got to be Dr. Liam Ring, who's a consultant cardiologist in West Suffolk Hospital, and he's the first author for the BSE aortic stenosis guidelines that came out recently. So he's going to talk to us about projected aortic valve area. Thank you.
If it works. Hello, thank you very much. I'm very grateful to be back, and I'm so happy to see everyone here. Honestly, it's lovely to get people back in face-to-face. For those of you who don't know me, I'm Liam Ring, cardiologist. For those of you who do know me, if I look or appear slightly less perky than usual, it was a big night. But I'm going to plough on and excite everybody with projected flow area. Okay, so aortic stenosis, kind of the theme of the session. We've all seen it. We know it's about these calcified, restricted valves. They don't work very well. What can we do to make them better? And we're talking about a sort of a slightly niche area. So I'm going to do a whistle-stop tour, if I may, very briefly about why or how we assess aortic stenosis and the principles behind that. Then a little bit onto these sort of nebulous patients with low gradients because they've got a bad ventricle, and then a bit onto the sort of the meat of the talk, which is projected flow area. Okay, so we all do echo here. Everyone will know this. The principal way we measure aortic valves or assess the aortic valve is using Doppler, and we look at velocity. As the valve becomes progressively more narrowed, the velocity across the valve increases, and we're very good at measuring velocity using echo, and therefore we're very good at measuring how bad a valve stenosis is, or aortic valve stenosis is. And so the cornerstone of assessment of aortic stenosis has always been velocity, or we can trace around it and get a mean gradient, but those two things usually correspond very well. And then we do valve area, as everybody will know, which usually agrees with the Doppler indices, and that's all fine and that's all dandy. And this is obviously how we do it. We have nice pictures, we take the LVOT diameter, we put our Doppler down, we get a nice tracing, we measure it properly, all the things that you guys are perfectly aware of, and then we go to some guidance, and never be one to shy away from showing off in some kind of vague way. We've got some guidance, which there's a lot of us wrote and took a lot of time and effort, but we're very pleased with. And the cornerstone, as I've said, is that Doppler indices. And as I said, most of the time, the Doppler indices and the valve area will agree as to how bad that valve is. But not all the time. And so clearly we're talking about this kind of scenario. So we've got a patient here who's got a terrible ventricle. That valve looks pretty chalky, it's restricted, it looks like it could be severely stenotic, but when you put the numbers up and you measure it, it doesn't necessarily add up. And the reason, of course, is that the velocity across that valve is very reliant on how hard you're pushing the blood in the first place, doesn't it? If you're not pushing the blood very hard, you won't get a very good velocity across it. That doesn't mean that the valve is not narrowed. So very often in this scenario, we get a low gradient or a low Vmax, much lower than you would expect for severe AS. And the valve area, however, very often suggests that it's severe AS. So great, so it sounds like the valve area is the right thing to do. And we'll come back to that. How often do we see this kind of scenario? Well, as you will echo, everyone will know, we don't see it necessarily all that often. This is a big database analysis from the States, and essentially there's just over 2,000 patients, and they looked at the ejection fraction at the point of diagnosis, and about 250, something like that, had an ejection fraction lower than 50%. Not all of those patients would have had indices that are difficult to describe, but a proportion of them. But that's the kind of numbers we're looking at. So we're getting to this scenario, we're getting to more to the meat now. When we talk about severity, we've mentioned it before, mentioned the velocity, mentioned the valve area. What do we talk about when these people with bad ventricles? So everyone prepared to ooh. I did an animation, which I'm hoping will work. Ooh. Okay, so we've got a low stroke volume. The and it opens up the valve, and we measure those three things that I've talked about. So here we've got a classic scenario, a Vmax of 2.5, a mean gradient of 15, but an aortic valve area of 0.7. So as we've said before, the gradient and the velocity look like mild or moderate aortic stenosis. The valve area looks like severe aortic stenosis. It doesn't add up. We've already said that the Doppler indices, because you're not pumping the blood out, there's not enough blood going out, they will probably underestimate, or they could potentially underestimate how bad that valve is. But equally, remember that the valve may actually not be that abnormal. It may be pretty normal. And of course, if it's not got much blood going through it, it doesn't have to open that much. And so although the valve area measures how much the valve opens, that may be overestimating the true severity. So wouldn't it be amazing if we could make the stroke volume get better? Wouldn't it be amazing if we could push more blood out of the valve? That would make everyone's life a lot easier, wouldn't it? And that's what we do. So we can, in this patient, let's say we increase their stroke volume from 20 to 70 mils. Suddenly, the valve opens way more than it was before. The Vmax has gone up a little bit. The mean gradient has gone up a little bit, but the valve area is now about 1.4. This patient has got moderate aortic stenosis and coincidentally had just had a poor stroke volume. Brilliant. Conversely, we may have increased that stroke volume. In actual fact, the valve doesn't open very much more, but what does happen is that the gradients massively go up, the velocity goes up, and the valve area stays about the same. So this person has got severe aortic stenosis. And it just so happens we can do that because we give people dobutamine, and that's exactly what we do. The principle being you make the heart pump a bit more, you push more blood out of the heart, and hopefully you get to the point where it's very easy to work out what's going on with that valve. And so we've been doing this for about 40 odd years, something along those lines. The top left is the first guide to describe it in the literature. They did it on about 8 patients, and then subsequently there's been these databases, you know, reproducing the technique, looking at outcomes, helping guide how we treat patients. So I sort of stole this slide from Sanjeev yesterday. If anyone watched his talk, it was excellent, and it was very good for me because I got to watch him first. But principally, we can divide it into 3 things that may happen. You've got this patient at the start who's got a low gradient with a poor pump function, and the options are either you make it better and show that it's got severe AS, you make it better and show it's actually not severe AS, so we confusingly sometimes call that pseudo-severe, but really what you're saying is it's just moderate AS. And the third thing, you actually might not make the heart better. If you give the dobutamine and not much changes, you're obviously not going to be able to interpret what goes on. So as I said, we've been doing this for about 40 years. So you'd think after 40 years, we'd be absolutely nailed on with how we do this, and there wouldn't be a single problem with assessing these patients. So let's talk about this true severe cohort. You know, you'd think and you'd hope that in all these studies, there'd be a really consistent way of identifying the patients that we put through for DSE, wouldn't you? And we are largely okay at that. Most of the studies will say that the ventricle has to be pretty bad, an EF of less than 40%, and that the gradient doesn't sound like severe AS, but the valve area does sound like severe AS. So most of the time, the studies do agree. Ironically, the guidance, certainly from the European Society, the American Society, completely doesn't agree with that. They say you can have an ejection fraction up to 50%, but there's, whilst not being very much data for that in the literature. But you know, most of the time there's an agreement there. You'd also think there'd be a real consistency of what we mean by true severe AS. In fact, there isn't. Occasionally, they'll sometimes say that the Vmax has to go to above 4, or the mean gradient has to go above 40, or sometimes the mean gradient just has to get above 35, or sometimes the mean gradient just has to get above 30, or sometimes you just don't care as long as the valve area stays less than 1. So in actual fact, when you go back and look at some of these database analyses, it's very varied what they define as actually this true severe AS. How do we know then that we're doing the right thing? You'd also hope that if we are identifying people with severe AS, that actually we know that they get better if we then treat them. In actual fact, we do tend to do quite well in that regard. So this is one of the earlier studies and shows if you've got people with true severe AS and operating them, they don't die, whereas if you don't operate them, they do die. Brilliant. So we know that operating helps these patients. Okay, now let's think about the other scenario. So we've got those true severe. Let's say we've given a bunch of people dobutamine and we've identified them as this pseudo-severe or moderate AS. Again, we've been doing this for 40 years. You think we'd be nailed on with working out what these patients have actually got and how we define that. And yes, you guessed it. No, we have not remotely come on to nail on what that means. There's a huge variation in the definition of pseudo-severe AS. So again, it's sometimes that the gradient doesn't go above 40 or it doesn't go above 30, or sometimes if if the valve area goes up by more than 0.3. It's very, very, very varied. The second thing you'd think we'd be pretty good at is we'd like to know that if you found somebody who's only got moderate aortic stenosis, you want to know that if you did operate on them, that wouldn't help. You know, the whole point is we're trying to identify people that don't need an operation. So we want to know that's the right thing. Well, in actual fact, we don't really know that either. So this graph is a sort of a Kaplan-Meier curve. These are a bunch of people, 86 from a recently published large database, all of whom had severe aortic stenosis. And you can see that the patients who did end up getting an aortic valve operation actually were statistically more likely to survive longer. So that's weird, isn't it? We've said that they don't have aortic valve disease, and yet operating them possibly makes them live longer. Does that mean we're not identifying the right patients? Does that mean there's something else going on? And that something else could be, well, hang on a sec, we're assuming that aortic stenosis is the same for anyone. If you've got a good heart and you've got severe AS, we know they need an operation. But if you've got a really bad heart, maybe just moderate aortic stenosis is enough to make things worse. Then maybe that will kill you. Maybe we need to operate on moderate aortic stenosis when the ventricle's bad. And actually, we don't really know that either. So there's one study that I could find, and we looked at this, that is published in the literature, and you can see it's got a number of patients included, 30. So we're talking about the management of aortic stenosis across the entire world, which is, 8 billion people, based on, 30 individuals. It seems a bit mad, doesn't it? But in this principle, what they defined pseudo-severe aortic stenosis was as long as the valve area got to be above 1.2 centimetres squared at peak stress and the gradient was less than 40. And that 1.2 is really, really important. And what they did that's unique about this particular study was they then took those patients who had moderate aortic stenosis with a valve area of more than 1.2, and they compared them, they compared them to patients who had heart failure, similar levels of heart failure, but with no aortic stenosis, and they propensity matched them, which means they were about the same age and they didn't smoke and there was no diabetes and all that kind of stuff. And essentially what they were saying was, when the valve area is above 1.2 after stress echo, their survival is the same as people who just have heart failure and no aortic valve disease, therefore implying that the aortic valve disease is not important at that level. Okay, so 1.2 seems to be important. And then, as I said, the third outcome is you can have something indeterminate. And indeterminate is when the heart doesn't get better and you just can't interpret things. Largely because, as I said, the pump function does not improve, but there's also some subtleties to it that. Here we have, and we talked before, I know people have mentioned it before, there's this idea of contractile reserve, which is if the stroke volume increases by 20%, we consider that contractile reserve. But that's a really disingenuous kind of statement. So let's take the same patients we were talking about before. The stroke volume was 32 mils. Let's say it goes up to 37 mils. That's not a contractile reserve. Unsurprisingly, we can't interpret the result. But what happens if it went up to 48 mils, or, it's still not approaching the normal level for what we would consider a normal patient. Here we talk about when you've got these patients without contractile reserve, it's traditionally been thought of being a really poor prognostic indicator, and they seem to do very, very badly. But this is a sort of a slightly more pertinent one. We've got the same patient at the top, low gradient, low flow. This one, they've got completely normal, nice big contractile reserve. You can get an answer. Here, this person's stroke volume has still increased by 20%. And yet, as I said, it's nowhere near the level that we would consider normal. So unsurprisingly, the results are almost uninterpretable again. What can we do in this scenario? And this is where we get to this projected flow area. It's been around since about 2006 when the first article was published. And it's a very simple principle, is that let's work out what the valve area would be if you got flow to be normal. That's great, isn't it? Rather than looking at what's actually happened when it's still not great, why don't you extrapolate out and figure out what would have happened if if the pump function of the heart was essentially normal, or if the flow were normal? And that's what the principle of this projected flow area is. And the idea is, and it seems to, improve the identification of the patients that are truly severe or not severe, and it reduces the number of indeterminate results, and it probably gets people to survive longer. We've mentioned this again, so stroke volume is not flow, it's just a static volume. We're talking about flow per time, so flow over seconds. That's flow rate. That's much, much more useful, and that's the principle of this flow area. So here's just an example. This is a patient at rest, the normal measurements that we would take. And we have this little graph, so we've got a mean gradient of rest of 16 and a valve area of 0.7. We don't know what the answer is. And then we measured the flow rate, which is the stroke volume over the ejection time. And now we've got a valve area and a flow rate, and we can plug this on our graph, which I then duly do. Oops, sorry. Too many clicks. This is when the... Yeah, so this is what we do. So we can plug that on that graph. Right, then we do the stress study. The stress study numbers increase, as you would expect. And what we do again is exactly the same principle. You plug it in. So we have the mean gradient of 28 and a valve area of 1. So that is not enough to say the patient is either truly severe or not severe. So again, we work out the stroke volume, we work out the flow rate, and then we can plug that on the graph. And from that, we can then draw a line. And from that line, we can then extrapolate, go up to what the 250 mark, 250 being what we think is a normal flow rate, and then you can see what the valve area would have been at that 250 mils per second. And that is a way of working out what projected valve area is. I don't know how much time I've got, so I'm going to speed up. So this was principally what they did, is they did a number of fake valves which they'd created and took photos of them. This is the little photos you can see, and worked out these all the theory, and worked out what happened when the valves increased, and calculated all this. And this is how they then demonstrated that it seems to work. So if you look at the mean gradient, what I've outlined at the bottom is that if you look at a patient with a mean gradient of less than 30 or a mean gradient of above 30, they could just be equally likely to be true stenotic or pseudostenotic. That doesn't discriminate. Effective orifice area doesn't discriminate. Projected, you can see, makes a really big discrimination between one or the other. And it's the highest percentage of correct classification. They also repeated it. That was on a created machine. Then they did it in a few patients just to show that the proof of principle worked. It's important that you do have some change in your flow. If your flow rate doesn't increase by very much, if the lines are too, it's very difficult to draw a line, so you can't calculate it. So there needs to be a more than 15% increase in flow rate. 2. Okay, cheers, buddy. Okay, so other key things to take away from this. What they then did is they then did a subsequent study demonstrating it seemed to work. But importantly, they looked at this EROA, projected valve area, of more than 1.2. That's why that 1.2 centimetre squared seems to be important. And they showed that if the projected valve area was more than 1.2, patients with severe AS or patients with this low flow scenario, if you did not operate on them, they did just as well. So that actually predicts a good outcome. So what that suggests is that as soon as your projected valve area is more than 1.2, the aortic valve is not important, and which seems to correlate with that other study that they've done from conventional methods. That's how to measure it. It's a relatively complicated graph or formula, but we can do that. Just to show that it does work. So I've had one of the graphs on this before, but this is a contemporary study published about 2 years ago, looking at 250 odd patients, all of whom have low flow aortic stenosis, impaired ventricle. And what they did was they undertook conventional dobutamine stress echo and divided them according to what the outcome was. And we know that about a third of them were true severe, about a third were indeterminate, and about a third were pseudo-severe in this cohort. True severe, unsurprisingly, operating on them made them better. Brilliant. Pseudo-severe, and this is the graph I've shown you already, despite apparently being pseudo-severe, operating still appeared to help some patients. So again, suggesting we're not that good. The indeterminate ones, and they couldn't work out what it was, and there was a third of those, again, AVR appeared to help intervention in those patients. If you then went back and re-evaluated all those patients using projected EROA, look at this. True severe AS by the projected methodology clearly works, but the pseudo-severes, no difference in outcome. So this appears to help really successfully discriminate between the patients that need an operation or intervention versus those that don't. And just in my last 30 seconds or whatever I've got, there's a huge registry now looking at patients, all of whom have been identified using this projected methodology. And it shows that many of the things that we used to think probably aren't true. The idea of contractile reserve, it gives you a bad outcome. Actually, patients who have no contractile reserve but have got severe AS using this method, their ventricles get just as better as anybody else. Their stroke volume goes up, even if their ventricles are very, very, very bad. So to summarise, this low gradient AS situation with impaired ventricle is a real challenge. We've been doing dobutamine stress echo for years, and I think we're now starting to get a handle on it. I think this projected process does help in a group of patients that you can't otherwise make a decision, and is better at helping to discriminate those people who would benefit from intervention that were those that wouldn't. Yeah, I think that's it.
Thank you very much, Liam, for the excellent talk. Our next speaker is Atilla Kardos, who's a cardiologist from Milton Keynes. He's going to be talking about low flow, low gradient with normal preserved ejection fraction. Thank you, Atilla.
Thank you.
Just setting up the computer here.
If anybody has any more questions, you can also ask those who get started.
Right, chairperson and colleague and attendees. The title I was given today to talk about it was aortic stenosis, low flow, normal ejection fraction. I was thinking about, so what can I do with this? It's one of the most boring topic one can have given to talk about. I try to translate into really talking about the products low flow, low gradient severe stenosis. These are patients with normal left ventricular function, but have got low flow in the alveoli area to measure and have got severe aortic valve stenosis. I hope you won't be bored to death. I try to make it a bit educational. And that will be the outline that I would like to cover today, to talk about the evolution of grading of aortic valve stenosis in general, to be able to understand the paradoxical low flow severe aortic valve stenosis phenotype development. And I will use the paradoxical low flow severe aortic valve stenosis interchangeably with the PLF, just to having a bit of a short abbreviation of that. I would like to cover also the capture of the prevalence of the PLF severe aortic valve stenosis phenotype, and understand a bit, is this a problem of the measurement, or is it a real phenotype? Minimizing error of measurements of the continuity equation related components of the alveoli area, alveoli VTI and aortic valve VTI, would it make any difference if those patients who have been detected after the appropriate measurements of aortic valve area by the correctly used continuity components remained in the PLF severe aortic valve stenosis group of patients? Who will be these patients? What's the clinical parameters of these patients? And does it matter? What's the prognosis of these patients? Do we need to worry about these patients at all? And we'll finish it off by talking about the management of these patients with products, low flow severe valve stenosis patients as per recommendation and guidelines. Almost certainly I will overrun, but I just put one more last point in there if you have got some time to talk about it. Very happy to put in a context of our latest research. So what's the evolution of aortic valve stenosis grading? In general, this goes back 42 years ago when JKO from the States has run the validation study of the continuity equation against the Golin equation. And their aortic valve area was set after this validation at 0.75 to describe severe aortic valve stenosis. The mean gradient, they said, it will correlate with more than 50 mmHg. In 1998, that's 10 years later, only when the AAG and ACC guidelines have defined the definition of grades of aortic valve stenosis to mild, more than 1.5 centimeters square, moderate between 1.1 and 1.5, and severe to 1 or less than 1 centimeter square. Note that they have not really used for grading purposes either peak velocity or the mean gradient. In 2006, the similar authors as the 1998 guidelines writers have incorporated now, based on the clinical outcomes, the peak velocity and the mean gradient, in addition to the effective orifice area by the continuity equation, into their guidelines. And they come up with this table that we do use all the time in our daily practice. Of course, this has been reiterated and used in the subsequent guidelines throughout, up to the 2020 and 21 guidelines as well, lately published both ACC and the European Society. But by forcing into category of variable the velocity, the area, and the gradient, mean gradient, we are committing ourselves to a problem. Because there will be patients who will have aortic valve area by a contractilation of less than 1 centimeter square. But they will have lower mean gradient than 40, and they will have lower velocity than 4 meters per second. So discrepant aortic valve stenosis patients have not been really highlighted and appreciated in these guidelines. And why should they have? There was no data out there to do and to say anything about this up till 2007. That's the time when a seminal paper by Atilla by the Peterborough group in Canada has looked at this discrepant severe aortic valve stenosis patients. That is the paradox low flow, low gradient, severe aortic valve stenosis patients, despite of preserved ejection fraction. They looked at the clinical characteristics of these patients and looked at their outcome. And that was a seminal paper where the paradox low flow, low gradient, severe valve stenosis have been introduced. But look at that, not until 5 years later, the guidelines picked up on this. So in 2012, the European guidelines have now endorsed and acknowledged the paradox low flow, low gradient, severe valve stenosis nomenclature, and from then onwards, it has been taken over and continued in all the rest of the valvular heart disease management guidelines. So what's the prevalence of this phenotype? Now, I've listed and borrowed some of the images from a published paper. All the three phenotypes that we are talking about, and you have heard some of my colleagues talking about the low flow, low gradient, severe valve stenosis with reduced ejection fraction, which I will take out from there because that's not a topic of discussion for me today. The normal flow, classic normal flow, high gradient aortic stenosis patients are the one that we do like to talk and see the most because that's a very easy and simple diagnosis to make based on the aortic valve area less than 1 centimeter square, the mean gradient was more than 40, peak gradient more than 4, and of course preserved LV systolic function and the stroke volume higher than, the stroke index higher than 35 milliliters per meter square. That classic normal flow high gradient patients group represents around between 50 and 70% of the severe valve stenosis patients group. Our topic of discussion today is the low flow, low gradient severe valve stenosis, the paradoxical low flow severe valve stenosis patients group. They are the ones that are characterized by aortic valve area of less than 1 centimeter square. That's the effective orifice area by continuity activation. The flow less than 35%, the mean gradient less than 40 parts per mercury, and the peak velocity less than 4. And of course, normal systolic function or preserved left ventricular systolic functions. They represent, depending on the literature that you take, between 5 and 25% of the severe aortic valve stenosis population. So that's the graphical presentation of our paradox low flow severe valve stenosis patients group and the components that we do need to measure during our echo acquisitions to make that phenotype, the diagnosis of this phenotype. And that is our left ventricular outflow tract area measured from the left ventricular outflow diameter. The aortic valve in itself, how it behaves, the cuspidality and the degree of calcific plaques on it, the aortic valve VTI and the LVOT VTI. Of course, we need to know the ejection fraction as well to complete the phenotype of these patients. So who are these patients? So the clinical profile of these patients are the one who have got reduced arterial compliance, usually related to atherosclerosis or increased systemic resistance, for example, due to hypertension, but also valvular arterial impedance. They are female in preponderance and have got small body surface area, small left ventricle size, and left ventricle outflow tract area. And these two are very important because if they were to be considered for valve replacement surgery, these are the two parameters that are making these patients more prone to develop patient prosthesis mismatch. And of course, coexisting conditions of these paradox low flow severe stenosis patients could be partly contributing to this phenotype, that is atrial fibrillation, mitral valve regurgitation, or restrictive filling patterns. We heard lots about the blood pressure controlling patients with severe valve stenosis thus far, and that's also valid for these patients to measure to phenotype them accurately. And of course, those patients who have got a very small body surface area, the aortic valve area should be indexed. So what does the guidelines say, and that has been for the last 10 plus years? Once we have measured the aortic valve mean gradient and peak velocity, that will fulfill the low flow, low gradient phenotype. We look at the aortic valve area less than 1 centimeter square. The most important thing, and that's what the guideline emphasizes on, is to correct for the blood pressure values, and they said that 140 or 8 mercury or below value should be the blood pressure that we are achieving in patients before we do the echo measurements of their flow gradient and velocity. And more importantly, to exclude measurements errors that may underestimate the gradient flow and the valve area, and then define the flow status. So that's the blood pressure that we need to try to achieve before we do the echo scan in these patients suspected for PLF. And how do we measure how do we correct for the measurements? And that's what I'm going to spend my next 5-10 minutes to go through. So that's the valve motion that we are looking at, the valve, how healthy and how restricted in its opening is. And of course, we are also measuring the flow in the outflow tract area and across the aortic valve. To get to the principle of the continuity equation. I do apologize for getting down to the basics, but I thought it's probably useful for us to reflect on this. The principle of the continuity equation is that of a cross-sectional area. By changing the cross-sectional area, it does affect the velocity if we want to maintain a fixed flow in a steady state. And that's what it will roughly mean. So if we want to keep the flow constant, and from 3 lanes of motorways we reduce down due to building work into 1 lane, then certainly the velocity has to increase by 3-fold to achieve that. And that's what is also termed as a base on conservation of mass principle. So the flow in other cardiac terms now within the LVOT should be equal with the flow across the aortic valve. And that's what I put it now into our equations that we know very well, the continuity equations and how we get to the aortic valve area here. The 3 main components of that left ventricular outflow tract area, which is the half of the pi square of the left ventricle outflow tract diameter, we multiply by the LVOT VTI and divided by the aortic valve VTI. I'm going to now before I do that, spend time to go through this. I'm going to just put you this one, and I do apologize for this philosophical kind of sentiment that I thought I may just put it to us here, because that's exactly that we are facing within the daily practice when we do assess our patients with aortic valve stenosis. Can we measure aortic valve area by the continuity equation correctly? Is it possible? Or are we just setting us into a task that is failing by definition? And why I thought that this question may be relevant to us, I put it in one long sentence. If you just focus on the highlighted words there, I'm going to read this out for you for 2 seconds here. So can we measure the aortic valve area correctly by continuity equations? We are basically doing, in a living subject, we try to measure the valve area and the flow of a highly regulated organ, that is the heart, that is hidden in rib cage, applying the theory of physics of fluid dynamics with simplified equations, calculating circular area from measuring the diameter of a non-circular surface, and time integrals in different structures of the heart at different time points, and hoping to provide the most accurate measurements of aortic valve area, stroke volume, and gradient. Even the most highly trained sonographer, like all of you here, who takes the measurements with no variability, this can be impossible. All we can do is to make sure the image and the flow acquisition and the measurements from those data are the most accurate. And that's what our task is in the daily practice. Let's go through now the components of the continuing equations to see how we should do it, Let's start with the alveolar diameter area, alveolar diameter. So the recordings and the measurements, these will be the themes that we are going to talk about as per the recommendations by Baumgartner's 2017 publications. So how do we record the alveolar diameter? We use the parasternal long axis view, we zoom it up, and of course we need to make some gain adjustment to optimize the blood tissue interface. Once we acquired it and recorded it, we do the measurements, which is relatively simple. We measure the at annulus level parallel with the aortic valve plane. Inner edge distances and mid-systole of the cardiac cycles. And that sounds rather okay. The problem comes that the alveolar area assumed to be circular, but in fact, in more than 83% of the patients is non-circular, but hourglass morphology. And you can see that especially in patients with moderate aortic valve stenosis, that's pretty much the case. And this looks like this. If you measure the aortic valve, or the alveolar diameter near to the annulus, in patients, in this 83% of the moderate to severe valve patients, you are probably getting close to the realities. If you go 5-10 millimeters below that, more proximally into the outflow tract, depending on how low you go, you may underestimate by between 10 to 21% or even more than 21% the stroke volume or the aortic valve area. Look at only 17% of the patients with moderate to severe valve stenosis have got cylindrical alveolar geometry, which means that the diameter is correctly used and the circular equations applied properly. But that's very mild. 3 minutes, thank you. Other problem is that the parasternal long axis view that we are measuring the aortic diameter from is a oblique short diameter of something that you can see here in red. But once we acquired it, that's the number that we can use, and we can calculate the alveolar area. You can probably appreciate how vulnerable this diameter is to help to derive the aortic valve area from. The recommendations, therefore, as a solution say that we have to just measure the alveolar diameter at the annulus level. We can use the hybrid method, where I think one of the speakers already alluded to, where the alveolar area is derived from the CT planimetry, and then it's implemented into the continuity equation to accurately describe the alveolar area. This is all the additional tests, additional expenditure, radiation potentially involved, and if it's done by TOE, it's semi-invasive. And that's what the Dutch group has shown to us. The other issue that we can do to help the alveolar diameter is to use a correction factor. And I do apologize for spending some time on this because that's our research group's achievement, that we have looked at in 400 patients with cardiac CT images, where we have derived the correction factor from, and a single number to our major surprise came 1.13, that if we multiply the left ventricle outflow diameter with, we are able to have a much better correction or corrected alveolar area that reclassifies patients from severe aortic valve stenosis to moderate aortic stenosis by 39%. And this could be uniformly used in a wide range of patients that we have shown in our reported report. And that's what it looks like. So in multiplicity reconstructions, we have measured the alveolar diameter, mimicking as an echographic parasternal long axis view. And we also measured the planimetry of the alveolar area that we then forced into a circle, assumed to be a circle, and we derived a diameter from it. And this derived diameter we divided by the measured diameter to define the correction factor. We then validated this on a French severe valve stenosis dataset registry on 1,450 severe valve stenosis patients, and with normal ejection fraction. And what we found is that 39% of these patients have been reclassified from severe to moderate aortic valve stenosis patients. Those who have been reclassified to moderate aortic valve stenosis, they had much better outcome. Patients with low flow using the correction factor have been reclassified by 77% into normal flow patients group. And you can see again, it had a prognostic implication. LVOT VTI, how we do measure the second component. Of course, we record it in apical 5-chamber view and 3-chamber view with a pulse wave Doppler velocity. The sample volume should be placed at a valve level and then to retract it proximally until aliasing disappears and smooth linear velocity curve spectral envelope is visible. The sweep speed should be 50 to 100 millimeters per second. And then the measurement itself is straightforward in contouring these signals. The continuous, the aortic valve VTI is using the continuous wave Doppler velocity assessment, recording again 5 3-chamber view. I would just raise the awareness and the important point to make it accurate. We need to do it from several views of the aortic valve, and that should require us to use the non-imaging probe, the pad of probe, from the apical 5-chamber view, the right parasternal views and the suprasternal views to get the appropriate and the highest velocity we can have, because that's the most important part of the aortic valve VTI measurements, not to introduce measurement error. So that's where we are now. So basically, a summary slide on the bottom here says that the LVOT area is easy to record by measuring the diameter. The measurement is easy, but there's high level of inaccuracy by assuming the non-circular geometry. That could be helped by either a hybrid method or the correction factor introduction. The LVOT VTI recording is easy if you know how to do that. Measurements is simple and a low level of inaccuracies. The aortic valve VTI, the recording is difficult, and we have to use the pad of probe to acquire the highest velocity here. Once we acquire the measurement is easy, and the high level of inaccuracy comes from the inaccurate pressure detection. This slide also tells us, and I wanted to point this out, that how complex and how powerful the effective orifice area of the aortic valve by the continuation is, since it incorporates the peak velocity values, incorporates the mean gradient values, captures the dimensionless index, the velocity ratios, and the stroke volume all in one. So if we measure all these parameters properly with the least error, we have got a huge, powerful value as effective orifice area to work on and to use in our daily practice. And that's, of course, in patients with preserved ejection fraction only. I have got 1 minute to summarize, and I'm halfway through my talk, so I probably just jump now to the summary. The bottom line is that basically those patients who are classified into the PLF severe aortic stenosis patients, the current guidelines recommend to perform a CT angiogram to look at their valve calcification, because the calcification of the aortic valve is correlating very well with the severity of aortic valve stenosis. In women, this calcium score is 1,300 or higher, and in men is 2,000. And once they have got this calcium score added to their values, then they can be managed. Now, is it important? Yes, important, because it has been shown by the Hachicha paper that the PLF patients, the product low flow low patients, have got worse outcome in this observational study over a 5 years period than the normal flow severe stenosis patients. More importantly, both the PLF and the normal flow patients benefit from surgery if they reach the severe aortic valve stenosis degree. And that's the meta-analysis of the 18 observational studies that have been recently published 15 years ago, to show exactly that the mortality of the low flow, low gradient patients or PLF patients is worse compared to the other phenotypes, and they will, all phenotypes in particular, but also the low flow gradient patients will benefit from aortic valve surgery compared with medical treatment. And that's the two major guidelines by ACC and the European guidelines have now listed the paradoxical low flow low gradient patients populations for class 1 recommendations in the states based on non-randomized controlled trials with this pooled observational studies meta-analysis. And the European says that intervention should be considered in PLF patients at a 2A class level. So that's the summary slide. You can read, I can say the take-home message probably is within that. Paradox low flow severe atherosclerosis patients is a new entity, only 10 years old. The paradox low flow prevalence of this condition is 20-25%. The accurate recording of and the measurements is essential because that's the crux of the whole problems. PLF severe atherosclerosis patient has a very poor prognosis and can be modified with intervention, class 1 and 2A. And that will be my next part of the talk, which I'm not going to give now, is that whether the flow should be taken as a phenotyping tools or whether we should use it as a prognostication tool. And that's based on studies that we have been involved in as well. And the provocative test is, do we need a phenotype of PLF or not? Or shall we just use them as severe symptomatic aortic valve stenosis patients as one group? I will stop here because that's my 10 extra minutes that I can't do for you. Thanks so much.
Great, thank you for that great talk. Can we get all these speakers up on the podium for some questions? We've got lots of questions.
Okay, we've got 5 minutes for questions. Can I start with maybe Shaun? We've got a question about stroke volume calculation. So I think on your first case, you measured stroke volume on the LVOT and the ejection fraction. You had different stroke volume and transvalvular flow. Can I ask which is the way we should be measuring it and why the differences?
Yeah, good question. I think there are errors in our assessment of stroke volume that come because of the two measurements we make. We make measurement of the LVOT diameter, and as we've just heard from Professor Kardos, that the position we make that measurement has a big impact on our calculation of stroke volume, but also our pulse wave Doppler positioning within the LVOT will determine what the VTI is, which then determines what our stroke volume is. So that's where the error lies in those two measures, and then obviously the angle of insonation and our alignment with the flow. So there are limitations with the continuity assessment of stroke volume. I think routinely, for me, I obviously always use the continuity equation in the first instance, but I think if that's erroneous and we've got good image quality of the left ventricle, then we can calculate, use 2D. If you have 3D, this is obviously going to be a lot more accurate, an estimate of stroke volume. The caveat being that any degree of mitral regurgitation will overestimate your calculation of stroke volume going through the aortic valve, because obviously that's going back through the left atrium, but affects your total stroke volume estimate of the LV. So primarily continuity, but if you think there's a discrepancy, and I'd advise everyone to always consider the stroke volume that they're calculating if they're finding discordance with the LV size, because so many times I've been asked to look at an echo, valve areas coming out askew, and the stroke volume from continuity is actually greater than your end diastolic volume of the LV, which is clearly not possible. So I think looking at both measures.
Perfect, thank you very much. Question for Stephanie. Do all BAV patients have aortopathy? And if they have an aorta which is not dilated, do they need surveillance of the aorta?
Thanks for that question. Good question. So I think it's at about 50%, so about between 40 and 70% of them will have aortopathy, so some do not. Yes, they all do need surveillance. Sometimes with familial patients, you do get the aortopathy without the BAV, so it's just part of the disease. So they will be under surveillance for their BAV, and so you'd be looking at the aorta every time as well.
Thank you. Question for Liam. If you keep your answers brief because we're going to run out of time. For projected valve area, what's the incremental value over calcium scoring?
That's not a brief. Okay, so my issue with the calcium score is that the calcium score was derived to identify patients with a valve area potentially of less than 1, because that's what was considered severe. Fine. But the point of these patients is that it appears to be that a 1.2 centimetres squared is when they are safe not to intervene. So I don't know what the calcium score is that represents 1.2 centimetres squared. So that's one issue I have. So although I'm very skewed because I like echo, but I would say that personally I think calcium score is useful if it's very, very high or very, very low, that's fine. But there's a lot of people in the middle and you should just take it with a slight pinch of salt. So I would use it very cautiously. If everything else doesn't give you the answer, that's where I think I am.
Thank you. A question for Attila. You mentioned accurate measurement of LVOT and ways to do that, hybrid CT and echo. What about 3D echo of the LVOT?
Yes, and certainly the TOE-based assessment, we heard about this in an above patient population. TOE is very important to measure the alveolar area appropriately because that might be also different shape from the degenerative aortic valve stenosis patient populations. TOE is absolutely fine. I think the to measure the planimetry-based aortic alveolar area, the parasternal imaging-based alveolar area, the long axis and 3D acquisitions, it still has got the problems of fidelity and the resolution that we can safely acquire and say about the alveolar area from. And that's what I certainly, I'm trying to use 3D in every single patient, irrespective of whether it's a valve disease or not valve patients. The parasternal images to get the full volume acquisitions and then to derive the alveolar, it has got major challenges. And those of you who does it in a daily routine, the 3D parasternal acquisitions, it is not easy. Let alone the accuracy and the resolution is not quite right there. It doesn't mean that in the future it's not going to be different.
One quick last question, maybe for Shaun, Liam, and Attila. In terms of blood pressure control, I noticed you all mentioned you have to assess aortic stenosis with blood pressure of less than 140 on the guidelines. How do you actually achieve that? Because lots of patients are very elderly. I would find that pretty difficult.
I think conventionally there's been this idea that we can't treat hypertension in people with severe AS. There was this sort of conventional teaching, and particularly conventional teaching that ACE inhibitors were bad. But I think there's pretty good evidence now that ACE inhibitors particularly are good, they work fine, and they actually improve prognosis in people with coexistent severe AS, or potentially severe AS and hypertension. And so it should be first line, but in the sort of older generation, the older population, you just perhaps don't be quite so aggressive with your blood pressure control, aim for about 140 millimeters of mercury systolic. That's my thoughts.
I fully agree with that, and I think we have got comorbid our patients with degenerative aortic valve stenosis are not single pathologic patients, but they're comorbid patients with all sorts of problems. And the simple measure that we can do is really just control the blood pressure. And many times, those patients with low aortic valve area and very high blood pressure, we do see sometimes by just controlling the blood pressure and coming back next time, they are coming out from the severe valve stenosis group of patients where we do know they will benefit from aortic valve intervention, and they are slipping into the moderate degree of aortic valve stenosis. Of course, there are randomized controlled trials that are targeting the moderate group of patients, and that would have been my last 5 minutes to talk about it. But at the moment, we don't have evidence in support of moderate aortic valve stenosis patients to be operated on. So the simple measure of just controlling the blood pressure will just make a huge difference for the current time.
Perfect. Thank you very much to all our speakers for your excellent talk. I hope you've enjoyed the session. It's been quite interactive, lots of questions.